Well, I'm going to ask Simon and Dr. Himelhoch to join us on the podium, and they are going to take on the responsibility of addressing the future of movement in mental health or mental health movement. So uh, I'm going to let you lead the way and tell me where we are after those 2 days of having presented so many facts, so many uh, clinical studies, and from Art Kramer's to what Jacob Meyer just talked about, and several others. Where are we, and where are we going, and how this is going to change moving forward?
So we can have like a little dialogue, which you are all included in the space. Um, so, Adel, thank you so much for offering this as a concluding idea. It's always hard to look to the future because there's nothing really to predict it. We can look to the past and hope it goes that way, but then these really amazing inflection points happen, and then all the past gets thrown out, and you have to think anew. Um, and when you asked the question, two ideas came to mind, at least for me. One is sometimes when we think about the future, we're thinking about novel, cool, neat ideas. And maybe things like AI come to mind, right? Because that's what everyone's talking about these days. Um, and I would say sometimes it's also important to look to the future by looking at places where there are really scrappy novel things that are happening, and particularly in resource constrained areas, that we can then apply to the work we're doing here. And what came to mind is something, Simon, you said that really impressed me, which was when you think about people who have schizophrenia, for example, who come onto inpatient units, maybe with this first episode psychotic disorder. And what I mean by psychosis is really problems with reality testing. So people who might see the world in very different ways than we are all agreeing on seeing the world. They might be hearing things that other people aren't hearing. They might be very paranoid or scared that people are watching them in ways that are intrusive to them. They may feel like things are implanted in their body that allows them to be spied upon. And these experiences obviously can be very, very difficult for them and for their families. And when they first start happening, it often lead to a hospitalization. And Simon pointed out that it sounds like in resource constrained areas, people are really taking on this idea of bringing exercise into that arena because the medication that often is used for these people leads to metabolic syndromes, right? With weight gain, diabetes, all sorts of things that, are very health limiting in the service of helping people's psychotic symptoms get normalized, if that is the right word. So I would like to ask you, Simon, if you could share a little bit about what's being done in resource constrained areas and how can we then, as we're looking forward to the future, implement them here in resource or resource heavy places like America or Australia or Canada.
Thank you. So, yeah, thanks. I'll just start by picking up where we left off at the last session, and just that last question about resources and as a doctor, resources that are available. So, a couple of things I'll just point you to. One, the World Psychiatric Association has the Healthy Lifestyles Hub. The current president of the World Psychiatric Association is very, very committed to lifestyle as a factor. So there's resources online. In terms of severe mental illness, the European Psychiatric Association also has guidance on physical activity as part of treatment. So that provides guidance around schizophrenia, bipolar, as you mentioned. There's one other, the World Federation of Biological Psychiatry. So Wolf Marks, who's another Australian, but he led some guidelines around using exercise and nutrition for treating major depressive disorder. So we do have a whole lot of guidelines with practical tools that provide these recommendations as well. The resource constrained settings, I think what's exciting there is that, if we think about research, and I'm sure there's a lot of people here that would have the same experience, it's getting harder and harder in places like Australia to do clinical research because the amount of governance and the restrictions and the cost is blowing out and becoming very, very difficult. My experience in resource constrained settings is that we're a bit more open to trying different things because we have to, because there's nothing else there. So if you're in a place like a refugee camp, you don't have the luxury of referring to a clinical psychologist or a psychiatrist because in Bangladesh, where Pao and I worked, I mean, there was one psychiatrist roughly every fortnight for about 2 hours in the camp who would be giving injections, and that was about it. So you had to think about how do you utilize that skill and expertise to train other people, that task shifting idea. Who else do you have available that you can bring in as part of that team? So I think there's a real opportunity to learn from that in high resource areas. And the final point about preventing antipsychotic induced weight gain. So again, there's a lot of resources from Australia, a program called Keeping the Body in Mind, or KBIM. It's led by Professor Jackie Curtis, who's a psychiatrist who's extremely committed to addressing physical health of people with mental illness. Jackie leads a group called IFIS, which is about the International Physical Health in Youth stream as part of the Early Psychosis Association. There are videos, there are resources, there's a whole bunch of stuff there. But essentially, the research that Jackie led showed that if we intervene at day one, so as soon as a young person is in contact with a mental health service, they also get access to a peer worker. They get access to an exercise specialist, a dietitian, and a group-based program that addresses physical health alongside mental health simultaneously. You can prevent the weight gain from happening. We've published data at 2-year follow-up showing that we maintain that benefit. So there's that critical period if we intervene early. Yeah, so it can be done. I don't think this is, as everyone said, this isn't a lack of knowledge. It's a lack of implementation. We know what to do. We know how to do it. The evidence is very, very clear. It's just about acting on that.
So just following up on that, what would be a way to encourage systems of care to implement these evidence-based approaches so that the communities could have the advantageous health outcomes associated with them?
So I can give you a concrete answer to that now based on some of our experience. So if we think about here, there are champions from both physical health, we've got coaches, physios, we've also got mental health champions. What we've had a lot of experience with is how do we create student placements so we get that opportunity for interdisciplinary learning. So for example, if you're here working in a mental health facility or you're working in we've heard some great stories. How can you go find a university, take some of Jacob's students, you supervise them? Initially, it's going to be a bit bumpy. But then what's going to happen is after 6 months, suddenly you've built some knowledge, you've created some expertise and some knowledge among a group of students, but also among your staff, because suddenly you know how to work with those students. We've got, I can probably give about 10 examples of this where we've done it in Australia. Nearly every time, money has then been found to employ that first student, and suddenly they become part of the staff. The evidence we have is very clear about integration. If we want these interventions to work, they've got to be integrated within the mental health team. If we have them as an outside, as a separate thing, if there's time, if we've got the resources, it doesn't work. So it's that priority has to happen from that true integration. So that student model, that university placement model, I think is a really useful approach because there's a constant pipeline. It's not that they're going to run out. So I think there's opportunities. Those exercise disciplines need more mental health exposure, physios, exercise physiologists. It's just a given. But it goes both ways. That's how I would, that's probably one thing that I would say we can all do or start thinking about.
Let me just comment. Okay, I can. It's working. Listening to Rebecca and Francine presentations, and also thinking about the whole picture of why we want people to be more physically active, community-based programs that encourage participation in physical activity seems to be a very simple and inexpensive way to bring in physical activity into the community, knowing that first, it does help with physical health, but we know that it is important from mental health standpoint. So I think if we can, think of it as a way that the Sega to better mental health to the community is to try to bring those kind of community programs. And one thing that I feel that is so important is children and bringing physical activity in the life of children, especially in communities where their access to exercise, access to a safe, active place is limited. I think if we could, at least start with that. It's a very simple undertaking. I realize it can be expensive, but it can also be very inexpensive to really try to bring the community together in having So I don't know what's your thought on that from that perspective.
That's not on. Okay, thank you. Um, what a wonderful idea. I mean, honestly, there's the hope for if we're talking about the future, the hope for our future is certainly with the children. And isn't it interesting that in our medical system of care, at least in America, whenever there are cuts to care, the people that get the hardest hit are children and the women who care for them, and also the entire environment of having children. I mean, it's just shocking to me that that is always a place where there seems to be budget cuts. And what a wonderful idea to bring community-based exercise, right, and make it accessible and easy to use. Um, I've seen it. Like there's definitely places where this happens, and now I'm speaking beyond my knowledge, so I'll turn to you and other experts in the room. And this raises another question: is why is it underused, and what is it about it that doesn't allow people to feel like, oh, this is the natural thing to do? Um, is it because everyone has a cell phone now, and it's so much easier to swipe right or swipe left or whatever you do on TikTok? Or is it just so much easier to be typing on your computer, right, than to interact with people? Or is it, we've just been lulled into watching things, right? Sitting is the new smoking, right? Just lulled into this atmosphere of like, oh, why should I get up? Why should I do anything? And we're actually training people to some degree to do that. So how do we reverse that? What kind of like marketing or messaging would need to occur to really enhance that kind of behavior? I don't have the answer. I'm just asking the questions, but maybe you have the answer.
Look, I don't have the answer to that, but just in terms of marketing and how we pitch this, and this isn't my idea, this came from my PhD supervisor, Phil Ward. But if we come back to that idea that people living with poor mental health at 1.4 to 2 times higher risk of cardiovascular disease, dying 15 years earlier, if there was another group of the population that experienced that sort of inequity, there would be outrage. There is this stigma around mental health, and we just accept that that's okay, and that poor physical health happens. And I think HIV is an example that, similar issues with drugs and the side effects. But Phil's argument, which he's made lots of times, which I really like from a financial perspective, who's going to pay for these interventions? He says, well, that money shouldn't come from mental health to pay for these. It should come from general surgery. If you're preventing diabetic amputations and you're preventing cardiovascular disease, and of course that's never going to happen, but I think that framing of the argument around this being a rights issue and where should the money come from to pay for these interventions, maybe it shouldn't just be from within mental health that we should be making this argument.
I remember reading an article one time about the World Health Organization reporting an increased rate of obesity in the developed world and the underdeveloped, in the developing world. Let's put it that way. So be politically correct. But they also noted that coupled with that, there's an increased rate of depression, especially among women. So really, when we're targeting weight loss, we're also targeting depression. I mean, clearly the two are intertwined, like you described. And I think that there is ways to to bring a community up to the understanding that yes, we are trying to, we need to fight, the risk associated with obesity, but coupled with that, we are helping, and preventing the rate of depression. Um, it takes a village, it takes a community, it takes a nation, it takes a government, it takes a huge amount of involvement in putting something together like that. I love your video that you showed about Just Run, and I remember when I was in some of the refugee camps down in Turkey and Greece, how empowered how the kids to being able to run a 5K or to run around the block because they're accomplishing something. They felt that this is something they could be proud of because there's really nothing else out there for them. So in reality, motion has a great impact on not only just our physical well-being, but clearly I have never in my entire life felt so empowered about what I'm doing from those few days I spent in the refugee camp where I saw these kids running and just cheering and jumping high and feeling so great about these people didn't have anything. They were living in a tent. They have minimal amount of food and shelter and clothes. So motion really very impactful. And I think if we can bring it to our daily life and hopefully to the daily practice of psychologists and psychiatrists in this country, I think we will have a better world. The question to you, Seth, in your practice, I don't know how many faculty members you have in the University of Chicago in the Department of Psychiatry and Psychology. How many of them are really, you think, aware of this information?
Okay. So this is just, I wish I knew. How about that? That's probably the fairest response. I don't know. But I can say that the way that the clinic is set up, it's not really, it's not set up to be able to provide that kind of evidence-based practice, right? So if someone wanted to say, oh, we think you should be exercising as a form of treatment, we don't have a place then to refer them to do that, and maybe a guided way. Or if we want to do strength building, like Jacob's doing, we don't have a place to say, oh, this is where you need to do that. If someone wants to run, we again, we don't have any of these things that we could, and maybe we have to get connected with cardiology that might have some of these tools, right, for cardiac rehab, and be more intentional about those kind of connections. I'm just thinking out loud, but my gut tells me that a lot of people are aware of the information, but don't feel like they can do much about it. And that takes me back to my own roots, which is in tobacco control, which is a lot of people see tobacco as being a problem, or using tobacco, particularly, um, you know, um, combustible forms of tobacco. Yet people feel ill-trained to target that as something for them to treat. They don't feel like they have the training to advise people, assess people, or refer people, or even provide, evidence-based approaches. So for something like tobacco, where we all can agree, right, very bad health effects, our population of providers are not really doing much about that, right? Maybe that's something that we need to challenge ourselves to think about with respect to movement and exercise as well. What is it that prevents clinicians from doing really meaningful treatments for their patients beyond reflexively giving medications? Because we know that so much of health is about what we breathe, what we eat, and how we move, right? And if we're not paying attention to that, we can just start throwing all sorts of medications at people, and who knows, like, in reality, if that's really what's needed. So I just took your question and elaborated on it. I hope that's okay.
No problem. Yeah.
No, you're good. Yeah, I mean, I would just follow up to ask you what would be needed.
Okay, so this is like a softball question. I'll just go on my soapbox for a moment. Something that really seems to get healthcare motivated is money. And if you create a value-based system where there's a checklist that says, you know, tobacco, are you screening and are you getting people to quit? Great. If you're making this like percentile, then you're going to get more money. Um, we know exercise is good for people. Are your patients being screened for exercise? Are they actually doing it? Great. You get paid more money. If you don't do that, guess what? You lose money, right? And this gets to what Simon was saying, which is the cost offset then becomes real because a surgeon's never going to be penalized for doing another surgery because, at least in America, it's really well compensated. So there's a reverse incentive to actually make people ill in order to get high end interventions, right? And until we can switch that through some value based metrics, that's what we're going to end up with, right? There's going to be a lot of people who are just like, yeah, I'll drink a can of, Coca-Cola, smoke a cigarette, and sit and watch TV until I have my heart attack, right? Or I have diabetes or whatever. That's not good healthcare, right? That's just the opposite of what we'd want to do. And it's going to take kind of a revolution in healthcare payment, I think, to get there. That's my opinion. So, but that's where.
Well, I agree. I think the profitability in our healthcare system is centered around sickness. You make more money, so and there's no incentive to preventing. I mean, I think there are some healthcare systems that are implementing some sort of a preventive healthcare program, but they're not coupling it with an incentive to the physicians that is providing the care. They sometimes, it has more to do with how it impacts their pocket line, how their bottom line, because by doing this, that they're saving money on this and that and the other, not necessarily on how it's impacting the care. Now, I'm going to present the question to the audience here. How many of you have learned, and I counting the number of people that were here, there's about half of what they were here yesterday. So a number of people have left us, actually, unfortunately. But how many of you sitting in the audience who attended the last 2 days feel that they've learned enough, or they've learned information during these 2 days that will materially impact how they are going to be practicing, whether they're psychologists, psychiatrists, physicians? If could you raise your hand? I see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. I am thrilled. I'm in tear. I mean, I honestly can't tell you how happy I am, because that's exactly what we want to convey to all of you. And hopefully each one of you will make a commitment that they will share this information that they've learned with 5 others out there in the real world, because it is true. Because if we all work together, the future and the impact of the work that I'm doing, or that we're doing, that this young man is doing, and many of the speakers that are here at this conference, it will be materialized, and we will make a difference, and there will be an impact on mental health services, and there will be role for movement in mental health. So I want to thank all of you. We still have time, actually. Let's see. I don't know. How are we doing on time? Oh no, 2:40. My God, this is it.
But that was
Perfect.
that was
Yeah,
that was a
please.
great summary. We should probably end there.
We'll end right there. Well, thank you so much. Thank you so much. I appreciate that. Thank you. Thank you. Thank you. Well, before we conclude this, I have a few things I want to share with you. In the planning for this conference that started about 9 months ago, I made every effort that the presenters have diverse areas of research and interest. I also made sure that they also have diverse age group. So we have younger scientists, and we have middle age, and we have people who have been in the business for 40, 50 years, because I wanted to give a broad spectrum of where things are across the board, but also wanted to remind everyone that two of the speakers who were the oldest in this conference had the most pioneering research and interest in how movement made impact in mental health. Art Kramer and Peter Gray were pretty clear about what they have to say, and they pretty much had all the information sitting there in front of them. And I remember when I actually started looking into my mission for the foundation, I was looking some information back in 2017, but by today, there are thousands and thousands of papers that are published on this topic. And with this conference, I wanted to make sure that you get a feel for that whole picture. I wanted to make sure that you have some basic science understanding, some clinical understanding, some practical understanding in how you care for people with trauma and others. So I hope that I was able to succeed in making this a reality. So you will be receiving an evaluation form by email, and please promise me the third time that you will fill them, because next year it's going to be bigger and better. We are going to have a better conference, bigger conference, more participation, and this is going to grow. I want to tremendously, from deep in my heart, thank all the speakers. Travel all the way from Australia via Mexico, from Chicago, from Adelaide, from Canada, from Ottawa. All these speakers that came in gave me their time, uncompensated, for what they have came in to do, but they did it out of their goodness of their heart. And they also came from Detroit. Where's Rebecca? Is she gone? Oh, I think she had to catch a flight. So thank him all, and I really appreciate that. And I am so excited about what we've had, because it was, in my opinion, a very successful conference. But also, I'm still humble, and I would love to hear your input, and hopefully we'll make changes to make things better. Thank you so much. As I finish every conversation I had with all the people that I work with, I love you all, and I thank you for your support.